It's probably a little bit early to translate into true clinical practice at this stage, but it's certainly something we discuss, and we feel more comfortable recommending less radiation for people who for example, can't have the radiation for various reasons. There are also examples of where radiation, PET scan, so I keep saying this, PET scan has been used to increase the intensity of therapy. So, for example, the people who didn't have a negative PET scan, there's basically the flip side of this trial was done in the German studies the European studies where people with a positive PET, so who didn't get a complete response to chemo, got additional chemotherapy, and it was shown to improve the outcome. So you can see that the PET scan helps us to basically sort people who've had a good response, who might be able to tone down the treatment, or who've a poorer response, need a bit more of a boost to get into that good prognostic category. Lastly, I wanted to share with you a very short vignette about a patient and then kind of lead into something else. We were referred a patient with advanced Hodgkin lymphoma. I think he was about 28 at the time. And he actually was on a drug that was emptying the immune system to fight the cancer. So, I mean, everyone's got an immune system. It gets a lot of chemo and can get often a bit beat up by the chemotherapy, but we use the immune therapy to kind of try and juice up the immune system, and it might act against the lymphoma. In fact, his disease was progressing on this immune therapy, so we decided to give some radiation. So he initially got a good response, but then 18 months after he started the drug, some spots appeared that weren't there before. So we decided to give radiation to this bottom stuff here, because it was the biggest part of him, and then we were going to follow up with the top half later to try and induce a response. But in fact, when we went back after the radiation and did a PET scan, in addition to the stuff in the pelvis gone, being treated very well, which we'd expect, all of the other disease above the diaphragm responded as well. So that's quite unusual, because I just told you that radiation doesn't affect things that you don't point it at. But very, very occasionally we get these responses called an abscopal response, where you give radiation to a localized part of the body and the disease everywhere responds. And so in this case we thought maybe it was because he was on this immune therapy that was exciting his immune system. And so we thought maybe the radiation has excited the immune system even more, and it's caused a big response, because he was clearly progressing on the drug beforehand. So that's quite exciting, because it's actually a pretty uncommon occurrence, but there are a number of trials out there now looking at immune therapy and radiation to try and almost prime the immune system to treat whatever malignancy you have. So it's almost like a vaccine, because the radiation goes and kills nasty cells, and when they die, they basically get cleaned up by the immune system. That's what the immune system will do. It takes away cells that are no longer useful. And in fact, exposing their insides to the immune system might almost prime your immune system to go and clean up more of the same types of cells around the body. So you could turn a very rare and noteworthy event into something that's just a routine treatment if we had the right responses and we knew exactly when to give the radiation, how much to give, and so on. There's probably also an effect in your normal tissue, in that if you give radiation to normal tissues, it seems that the immune system gets upregulated. So in addition to treating the tumour and killing the tumour and exposing the tumour, there's probably also some kind of almost host effect of your body getting upregulated to fight whatever the tumour it is. So I don't know if Eliza was involved in this, but certainly, did she? Yeah. So we actually went to the Victorian Cancer Agency with this type of concept to treat aggressive lymphoma that relapsed people who couldn't get standard therapy. Could we give them an immune modulator and give 5 doses of radiation to almost prime the immune system to see if that improved the response rate? So without the radiotherapy, we're expecting about a 30% response rate, which isn't high, but is, for patients who don't have a lot of treatment options, is actually pretty good and very non-toxic way of delivering therapy. But if we could give 5 small doses of radiation and make that, 50, 60%, we could really open up the door to, that might even skip higher and, more early in treatment of aggressive lymphoma. So this trial is due to start, I think, in the new year. We're just going through the ethics process now. I think it's about $500,000 worth of funding, so we're doing a lot of other PET scans and molecular tests to figure out exactly who gets this response. But it's actually a very exciting part of cancer research in Victoria that's run through here at the Austin. The final thing I wanted to speak about was radiotherapy and big data. So everything I've told you is accomplished in radiation with computers. We couldn't do our jobs without computers. It just wouldn't be feasible. Especially all that technical stuff about turning the treatment on and off. And, you can imagine. And every part of that is actually saved on the system. So, elsewhere, there's this talk about big data. And I think, I don't know exactly what big data is, but so the views in this slide are not actually mine or the Austin's, they're someone else. So everyone really wants to do big data. But when I think about it, I know that we collect lots of data about one patient, because everything I've told you happens to a patient, and we just collect it all. There might be, I might have a lot of patients at my centre. Maybe I've got 6 or 100. But probably the true power of this data is if we could use it across centres. If we could have 3 centres, lots of data from lots of centres, we could have a very complete picture of radiation practice, maybe in the state or internationally. We'd be able to study very rare tumours, because if I treat 100 patients, maybe I've only got 1 or 2 rare tumours in there. But if I pulled 100 centres together, I could have 200 patients, which is just unthinkable for certain tumour types. I was treating a guy with a parotid tumour the other day, and I looked up the literature, and there were 4 cases in one, in each case report. You think, well, how can I make decisions based upon 20 patients spread across 5 institutions? This is the way to do it. You could study rare mutations, so we could start to track tumour mutations and then pull them into a central database and see who responded to radiation or chemo, and basically treat people according to mutations rather than just looking at them under a microscope. And finally, we could use computers to help us to make decisions about a patient. So maybe a PET scan is a very easy one to make a decision if it's there or it's not there, But maybe it's more how big the tumour was, how much sugar it was using at the time, how many spots there were. There might be a number of other smaller things that we could never predict as humans that computers could help us to find the answer. And having those types of things need a lot of numbers to do. There are lots of problems with this type of approach. So maybe we don't really want people transmitting all health data across the internet to somewhere else. Every day there seems to be a data breach outside of health, thankfully. And in fact, there are very strict rules in Victoria that govern the exchange of health data for research and otherwise. And I think it probably wouldn't be that feasible to effectively create a master database somewhere up in the internet of patient data. Another problem is if I design an algorithm that works well to predict a certain thing here at the Austin, it might perform very poorly somewhere else in Victoria or even in another country because their health system's different. Maybe even the patients that I'm seeing are different to their types of patients. So having a number of different centres pooling data would be fantastic, especially internationally. And obviously the numbers game, more numbers is always better with respect to predicting the future. The better picture you have of the situation and the more resolution you have in terms of numbers, the better it will be. So I've just told you that really we don't really want to be sending data across the internet. I think that's a big no-no. I think it's not really that feasible. So what people have come up with in radiation oncology, and we're hoping to extend the model further, is to actually have a boffin factory. And what we would do is keep all of our data here in the Austin and put it under lock and key. And we ask the boffins to write computer programs and send them into the Austin. And we run them on our computer. Then we send the data back to them. So they never see, they only see the result of the experiment, not the actual data that go into making the experiment. So they can see what's in the box, but they can't see individual parts of the box. Which is actually quite a clever way to do it, because it means that you don't need to send the data across the internet. They just send you the program and you send back the result. And the guys that we're working with in the Netherlands effectively have done research to show that even though they can't see the actual data, they're just writing programs and sending them off, they can still get to the same result as if you could see the data. It just takes them a bit longer. So the idea behind this is that we're hoping to join this collaboration of international, so it's Netherlands, US, UK, other parts of Europe, to basically try and form a federated model of research. So we could contribute our data or have the rights for them to run programs on our data to basically learn from that experience. So that obviously goes, it's quite a new model, so we need to go through the ethics process to make sure that everything's been ticked off nicely and that we control where the data lives and so on. But I think this is actually the future of healthcare. I don't think it's just radiation, I think it's healthcare. This is the way that needs to be done, because it doesn't put people's data at risk. So I've given you a very short kind of update on radiation and almost a history lesson. So some take-home points. Radiotherapy isn't a very effective anti-tumour agent. It's been used for decades in fighting cancer. The biggest advances that we've had really are in targeting and delivery of the treatment. But I think we shouldn't underestimate technologies like PET in terms of improving, selecting who needs the radiation and designing treatment courses for patients that are individualised and personalised to that person and their disease type. Obviously, I've a vested interest in immunotherapy because we're running a big trial, but if you look at cancer research as a general kind of a summary, one of the biggest topics at the moment is how radiation fits in with immune therapy, because it does seem like there is some kind of additive effect to try and basically prime the immune system to help to combat malignancy. That's all I had, so I don't know if I've gone over time or
no, that's all right.
any questions?
I'm just interested in understanding what the risk of PET and CT scans is in causing further cancers.
Right. So we do a lot of radiation safety and protection in radiation oncology. But it depends a little bit on the type of scan that you're doing and how much of the body you scan. But usually, say for example, you were doing a chest CT scan for screening for lung cancer, for example. I think that's kind of a similar radiation exposure to a long international flight, or about, I think it's about a dozen chest X-rays, or maybe a bit more. So depending on, but it was if you had obviously if you're in a car accident that scanned your whole body, that would be a lot more, because they'd be also looking for leaks in you and using a lot more images. But the actual risk from diagnostic imaging is pretty low if you look at the actual kind of risk at a population level, if that makes any sense. So it is, all radiation, cancer from the sun causes radiation, I've told you, and if you look at the radiation exposure at a population level, probably I think it's about 30 or 40% comes from the ground, your basement, radon in your basement, those types of things. I think about 15 to 20 or maybe 25% comes from diagnostic X-rays if you look at the population. So in fact, the contribution, I think, from diagnostics is pretty small in terms of your overall radiation exposure. The big thing is it an avoidable exposure? Because you can't avoid going into your kitchen to get a glass of water, but you can avoid going for a CT scan. And I think it's the justification that really drives radiation safety. So is it are you doing the scan for a proper purpose? If it's to detect a cancer which could kill you, then yes, it's very appropriate. If it's because you stubbed your toe and you're worried about it because it's still sore 2 weeks later, it's probably not appropriate. They're the types of decisions that we make. Does that make sense? Yeah.
Can you do radiation if you've got two tumours that come back in different parts of your body? Can you do the two spots?
Yeah, I've shown you relatively simple ones because you can definitely see where we're hitting it. But we do routinely treat lots of different spots with radiations. Just depends a bit on the circumstance at the time.
Just CT and PET, are they similar in like the amount of radiation or the? Or is one?
That's a good question. I actually, so the thing about the CT is that, so a PET scan is a whole body scan. So what happens is you get basically a little match head of radioactive glucose and you inject it to the body. That's a very, very small radiation exposure. But you also have a very sensitive camera that can detect the specific emissions from that glucose. In addition to that, most modern PET scanners will have a CT scanner attached to the PET scan. So if you go all the way back here, you'll get this image from the PET camera, and you'll do a low-dose CT on your PET scanner. So most scanners these days are PET CT, or maybe even PET MRI. And so probably the biggest radiation exposure comes from the CT part of it, because you have to CT the whole body, and what we would do is a low-dose CT. So you sacrifice the resolution, but because you've gained additional, I guess, biological resolution from the PET scan, you don't mind so much. And I guess the thing is, you compare to the CT, we often usually only CT kind of portions of the body. The answer is I'm not sure about which is more, but it probably depends on the type of CT that you're doing and how much of the body. Something like I was once told, I remember the radiologist said, it's all about how many pictures they take at the time. So if you're studying like blood flowing through a blood vessel that is kind of almost millisecond, you want to see where the blood's flowing and so on, and check for leaks in the body, like in a car accident, then you're going to be doing a lot of projections, a lot of X-rays that make up the CT scan. So the actual amount of radiation goes up sharply. But if it's an area of the body that's small and limited, like the neck, and it's not that thick, so you don't need that much X-ray to get through it, then it's obviously a lot easier. My feeling is that no one regards overseas travel as an avoidable risk, and the reality is that you are going up above the sea and you're getting radiation in the plane, and you can avoid that, but no one kind of thinks of it that way. But people worry about a CT, and a CT might be the same as an international flight or whatever. So I think that the risks are somewhat out of proportion in my mind, but they're still important because, as I said, it's the justification that's important.
It's justifiably appropriate to go to Hawaii.
Exactly right. That's exactly right. Yeah. But the airplane companies don't tell you that.
Yeah.
All right. Thanks, everyone.
Thank you.